be able to introduce some of the people that I've met in the last few months that are doing amazing work with the pandemic. And I think the first speaker we'll have is Dr. Pia Sofor, who has done just some amazing work over her life. She is the founder and CEO of TeachAids. She's adjunct faculty at Stanford. She has been long working with problems with traumatic brain injury and HIV awareness in many, many countries, and founded the nonprofit TeachAids, and has been working with COVID now for the last like a year or so. And I was actually introduced to her through Friends of Friends, and have been working with this wonderful program she has to create a database of real news called COVID-DB. And she has students collecting news articles and then experts curating them. So without further ado, I would like to introduce Pia to speak.
Thank you. It's so good to be here. I've heard a lot about this incredible group of people. So thank you for everything that you do. We need all the support that we can get, as we know, around the world. So I'm going to start off with a quick video. I find it's easier to communicate through pictures. So here we go. Can you guys all see this?
Yes, we can see it.
Prevention of HIV. It begins with me. Hello, what can I do for you? Doctor, I've heard a lot about HIV, but I don't really understand what it is. Could you explain, please? Sure. It's a very serious health topic. HIV stands for human.
This is the story.
This is the story.
This is the story of a breakthrough.
Breakthrough in the global fight against HIV and AIDS. This is the story.
This is the story.
This is the story of a new approach. A new approach to prevention.
That outperforms anything else in the world.
And is designed for those who need it the most.
In their own language.
And respecting their culture taboos.
This is a story of pedagogically grounded.
Evidence-based software from Stanford University.
That in a few short years.
Has become a movement of more than 100 NGOs.
And 70 nations.
And hundreds of volunteers
from around the globe.
who have donated their time, talents, and celebrity to the movement. This is the story of millions of boys and girls.
Men and women who, for the first time,
Know how to prevent HIV and AIDS. This is the story of TeachAids. But this story has just begun.
our vision is to provide this life-changing software free to everyone in the world who needs it
In the next 5 years.
But we can't do that without your help.
Without your help.
Because this story is also about you.
And what you do right now.
So I thought it'd be fun to start off with a video to showing some of the work that we've done in the past. For this presentation, I'll focus primarily on our work in India, given the current climate. So I love starting with this picture. These girls always inspire me from Andhra Pradesh, learning about HIV for the first time. So although there's been a lot of progress in the fight against HIV and diseases that are similar to that, sessions like this don't happen as frequently as we'd like, and that's because there's still many challenges in providing HIV education in India and other parts of the world. There are more than 33 million people living with HIV, and 95% of the infections are still in the developing world. TeachAids was founded in 2009. It was spun out of my dissertation work at Stanford into a nonprofit. And while I was at Stanford, I had read reports out of India saying that it was to be the next hot zone for people living with HIV. And that despite hundreds of millions of dollars that were poured into this kind of work, awareness campaigns, that the knowledge levels were still low. So I wanted to understand what was not working. One of the major problems was that the link between awareness campaigns and knowledge gains was broken. So talking about HIV, as you can imagine, means talking about sex and intravenous drug use and death and all these other topics that are considered taboo in many cultures. So unlike, say, anti-smoking campaigns, an increase in awareness didn't necessarily mean that it was an increase in knowledge, since the topic, again, was taboo to be able to discuss. So even though there were millions of dollars that were being poured into HIV awareness campaigns around the world, it didn't necessarily mean that people were learning. And because of the taboos, providing comprehensive education, HIV education of any form, was difficult or impossible. So here's a picture of a demonstration in Uttar Pradesh, one of the largest states in India, where HIV education materials are being burned. And the people who are doing the burning are the school teachers who had received the material to teach in their classrooms. Turned out that sex education was banned across multiple states in India. And since HIV education was typically taught as part of sex education, it was either watered down or not given. But in places where it was not explicitly banned, like in this picture, educators and parents often rejected it harshly. So as a result, when we conducted our baseline study to find out how many people knew about HIV, our findings were the same as the research reports that came out earlier and that we had read about in the press. And that they showed there were major gaps in understanding of basic HIV related concepts, like whether you could get it from coughing or sneezing as such. So we wondered, what if we reimagine the way we teach about taboo topics, and in the process, are we able to overcome some of the cultural and roadblocks in providing such education? So we brought together a team of interdisciplinary experts to conduct research on new ways to teach about taboo topics. And the first step was discovering how to strike a balance between comfort and clarity. So these are images from actual HIV materials we tested. On the bottom right, you can see stick figures, which are extremely comfortable to look at, but too simple to understand what's happening exactly. And then on the top left, we have medical illustrations, which are clear, but often considered immoral or banned. So the question was, what kinds of images do we need to maximize comfort, clarity, and therefore learning? So we started testing a number of images that were used in HIV education in India in particular. These numbers here are how uncomfortable people were with these kinds of images. In many cases, the materials were adapted for medical illustrations developed in North America, which turned out to be completely unsuitable for other cultures. But we discovered through additional testing that we were just a few steps away from a perfect set of images. So for instance, here in this picture, there was just too much of the woman's breast that was exposed. And so by reducing the amount of skin, more people were comfortable with the images. Same situation here, too much skin that was shown on the bottom half. Here we borrowed from a number of ideas from old Bollywood movies. So we couldn't show a couple kissing, for instance, but we could show them come really close to kissing, and instead you'd see these birds kiss instead. For any of you who've seen Bollywood movies, that at least in the past was quite frequent. The result was that over 98% of learners were comfortable with the approach. One of the Stanford advisors said that this is in Disney territory, which was really amazing given that it was HIV education. And the software also showed dramatic gains in learning, retention, and outperformed standard education approaches. But aside from learning, what we really wanted was much more. We wanted people to implicitly trust the content and love the materials. So the next step was getting the right voices. We worked with a number of celebrities, trusted celebrities who donated their voices and their avatars. We partnered with India's central government as well as every single state government to roll this out across the entire country and onto TV stations like Doordarshan, private and public stations that all showed it, a number of NGO partners. And then from there were several other countries we ended up working in. So these are images from Botswana, where they rolled out their version with their celebrities into every single school across the country. We eventually expanded into 82 countries, and the content was used in all different contexts. and including lots of places where there was no electricity or, more modern technologies. So let me see. I'm going to show another quick video, which will show a recap of the work in India. Oh. Here we go.
Prevention of HIV begins with me.
It begins with me.
It begins with me.
It begins with me.
So after instituting the HIV education into 82 countries, we expanded our work into head injuries, as Kristen mentioned. So in the US, we're partnered with 22 of the US Olympic Committee's sports governing bodies, like USA Hockey and soccer, baseball, gymnastics, the National Council of Youth Sports, which serves 60 million kids here. But I'm going to skip over the head injuries work and go straight to what we're doing in the COVID space. COVID-19. Let me. So as Kristen mentioned, it was about a year ago, in last, I guess, April, that we kicked off in 1 week, a number of volunteers that came together to kick off this website. So the number one thing that we were hearing from all of our partners around the world from doing the HIV work and infectious diseases was that there was a desperate need for trusted resources. You go to Google, you don't know what you're getting. A similar situation as what we saw in HIV that we're also seeing today. And so here we had a number of different experts pull together and continue to pull together resources that we can put into this database, as well as students that are pulling together different resources that are then vetted by experts. We started a video series, which we're going to more actively participate in now, that answers some of the burning questions that were coming up around, cybersecurity and privacy and women's and violence that was increasing. In addition to that, we a couple months ago launched a kids site, because a lot of the parents that were coming to us saying we've got to talk to our kids about these topics and we don't really know how to talk about them. And so all these different topic areas like hand washing and face masks, etc. We pulled together resources from around the world that were, again, expert vetted into a platform that could then play the series of content. So there's a lot of help that we would love from the specialized people on this call on the COVID work that we're doing. But that's a little bit about what we've done in the past 10 years.
Thank you.
I hope I was okay on time. I tried to limit slides and talk quickly.
No, you were perfect. Thank you so much for that, and just that's amazing work. And I think it dovetails so nicely with what PathCheck is trying to do in India right now with COVID, with trying to reach communities. And, it just started my head spinning about the villages and how to reach them, maybe for COVID, for, vaccination and that kind of thing. So I think we'll hold questions till the end, but I'm sure we can talk more about that. So thank you so much. So our next speaker is Professor Caitlin Jedalina. And so I learned of her work actually through Facebook. So I have a friend who is a giant fan, my friend Eve, and she said, you should see this person's blog. They're doing an amazing job. And I checked it out. And for the last couple of months since I've been aware of it, actually, it's been one of my go-to references for day-to-day updated scientific COVID information. She's doing an amazing job of communicating to the public really hard science concepts that are happening in the moment. So, but ahead of the preprints, what's happening right now, in a way that the public has just really appreciated. Her blog has reached 18 million people. It's translated in 6 languages. I personally repost it all the time. I get some of my news from there as well. Professor Jedalina is a professor of epidemiology at UT Health. She normally studies gun violence, I think, but has been focused on COVID, as I think a lot of us were. It's kind of hard to look away at this point. So without further ado, please welcome Professor Jedalina.
Great, thank you so much, Kristen. Yeah, I am an epidemiologist. Before pandemic, right, pre-pandemic, I am actually a violence epidemiologist. And so I look at how, in my day job, how violence is spread like a contagion, and to find patterns, because if we find patterns, then we can prevent it. And so, back in March, so I'm trained in infectious diseases as well. And so back in March, and since, it's been an all hands on deck approach to the pandemic. And so I've been pulled into COVID as well as my violence epi stuff. But I'm going to kind of talk to you guys today, and I'll share my slides about my night job, I guess, in translating science for the layman, and what this has really transformed into over the past year. So let me share my screen. And I too took these slides from a different talk to try and break it down to 15 minutes. So hang in there. But I always kind of point out in the beginning that this has actually been 2 pandemics, 2 concurrent pandemics. And I like to focus on how there's been a pandemic of disease with COVID-19, but also a pandemic of misinformation. And this is typically due to lack of communication, or more so lack of consistent, concise communication that's translated into English, right? So people understand. And I'm gonna walk through this pandemic of misinformation and what I've learned along the way. So like everyone else in the United States, March 2020 hit, and we were inundated with data. And from an epidemiologist perspective, we were scrambling for data, right? We were trying to make sense of the patterns to inform policy. We had to scramble on how to display the data, right? This was before the 2 million dashboards we have today. And then we had to figure out how to communicate to the public of what was going on in the science. And all of this, I'm going to call my phase 1 of data-driven updates. And so also in March 2020, my dean of the university knew I was keeping track of this data, knows how much I enjoy educating our students. And so she asked me to write daily emails to our students and staff about what was going on. There's a lot of confusion, a lot of anxiety, a lot of information. And so this was my first email. It was on March 18th. And I called him your daily data-driven updates. And this was me at night in Excel, honestly working with dirty data, just trying to make sense of what was going on and what we can prepare ourselves in the United States for. And so this was an example of looking at the Italy data and what happened after quarantine versus before quarantine in Italy. So then after a couple of these emails, one of my students highly suggested or strongly suggested that I start a Facebook page. And so she could share it easily. So she didn't have to, forward this and figure out everyone's emails and so use it on social media platform. And so that's when I created this page called Your Local Epidemiologist with the intent to close the communication loop, translate this public health science for everyday use. And I, at first, I think I had about 300 followers, which I was so excited about. Because this means it was beyond my mom, beyond my sister, beyond my students, right? That it was starting to spread. And so I just continued. I continued to do posts. And in April 2020, my posts really focused on how cases were changing, right? Where our new epicenter is going to be. Focused on comparing to other countries. Right in April, this is April 2nd, 2020, we were on the same exact trajectory as Italy in terms of cases, which was terrifying. Italy is that dotted line, and the other some states are the other colored lines. We also looked at CFR, so case fatality rate. What was our trajectory on that? Thankfully, we weren't following Italy's trajectory on case fatality rate. The United States was stable, but we needed to know why. Why was this happening in Italy? Why was it happening in Spain and not happening in the United States and not happening in Germany? And so these posts try to explain that to the best of my ability. We also looked at, I started focusing on COVID as a leading cause of death. This was on April 7th, 2020. COVID was the 13th leading cause of death on that day. And we now know it's the third leading cause of death in the United States in 2020. And I explained why it was going to be the third leading cause of death, predicting that. Also, I try to explain to my followers the value in being innovative with data. So right in the beginning, epidemiologists had to scramble for data in very innovative ways. And so people like myself partnered with other kind of companies like Google, and we use Google phones to track how people moved and how is that predicting transmission rates in states. And so that was another one of my posts. And then, at the same time, I helped develop a dashboard. And we met every week, and this was a true multidisciplinary team. And I try and highlight this with my students that not just one person can create a dashboard. You have to take the perspectives of multiple people. So I worked with biostatisticians, fellow epidemiologists, health behavior scientists, data scientists, that they can actually make our vision come true on Tableau, as well as students. We had a lot of students help us in this matter. And so we ended up developing a really robust dashboard called texaspandemic.org. This is just for the state of Texas. It goes down to data in each county, and it's been used widely. I think it's about 30,000 clicks a week to our dashboard. So we're really proud of it. The thing I'm most proud of, and I still to this day don't think enough dashboards do this, if at all, is include an interpretation for the layman. So what does an art not mean, right? What does this prediction mean? What is this daily case trend meaning? And so people other than scientists can go to this and really understand what was happening in their community in real time. And so the summer hit, and the summer, if you remember, cases were actually pretty stable. New York was coming down. And so I transitioned from data-driven updates to my phase 2, which was scientific translation. And I did this for a couple reasons. One, I'm a one-woman show. And two, scientific literature was starting to come out, right? Because data is delayed, but finally we're starting to get peer-reviewed articles. The problem was that we have a lot of systems in place in which scientists to scientists can understand and disseminate information. We are significantly lacking to this day a method and a forum for scientists to talk to the layman. And not only in a one direction, we need to make this two direction. And so this is what I tried to do with this blog, is really listen to people. And so I updated on what's happening with schools in other countries, what are evidence-based relative risk indexes, how can they make data-driven decisions, as well as how do you fight misinformation, right? What is a meta-analysis, right? How do you explain that to the layman? Why aren't more meta-analyses done? What did people find? And more importantly, what's the translation? Why should someone, a Joe on the corner street, care? And so I continue to do that, one with hydrochloroquine, another, obviously, COVID's not like the flu. What happened? What was this change at the CDC? And then also, I include data sources. And not like data sources to New York Times, but data sources to the scientific article. And so people can go and see the science and try and read it themselves, even though they may be able to, some may go over their head, but they now know the direct source of this science. And to me, that's been incredibly important throughout this whole process. And then we go to phase 3, I would call, and this is in fall, and when we start talking about behaviors. And this really is when, I don't know if you guys remember, I'm sure you remember, but is when pandemic fatigue starts hitting the United States hard. And so my goal with this was to continue to use scientific evidence, but in a way that showed people why it's important to stay alert and stay vigilant. For example, talk about case studies, for, on an airplane. What happens if one person is infected on an airplane and people don't wear masks? How fast does this spread, and why does this spread, and where? Or again, there's a really classic example of this Maine wedding in September 2020, where 127 people got infected. 8 people died because of that wedding, and they did not attend the wedding. And showing why this event or your behaviors can affect and will affect others, even hundreds of miles away. And so educating of why these behaviors are important, but in an evidence-based, data-driven manner. Also during the fall 2020 is when I started getting into infographics. This was when I created to get information across about this was Halloween. How do we have a safe Halloween, right? Not everyone's going to listen to the CDC and stay in their home. So what can we do? What's the least risky and what's the most risky? How can you make the most risky less risky? For example, a costume mask is not the substitute for a cloth mask, and here's why. And then also, I use my position in my blog to show real world examples that, hey, Halloween's really important to me and my girls. This is what I'm doing. I'm creating a candy land. And so people can walk up to my yard, get candy, enjoy the holiday, but I'm staying 6 feet, 10 feet, 15 feet away and waving to them and drinking my wine. And so explaining to them that we can be smart and still live our life. We just have to do it in an evidence-based way. And then, of course, we get to phase 4 in the winter, and this is, as you can guess, vaccinations and variants. Not only what's happening at the FDA level, right? Finally, for once, people are actually interested in these FDA meetings. What's happening in terms of side effects, right? And then what is happening in other countries that are ahead of us, right? Where is the goal? Where's the light at the end of this tunnel? And I go back a lot to Israel's massive vaccination campaign as well. And then also love to include this vaccine table, and I actually update it very regularly on this is super muddled, but what's the overall efficacy? How are variants working against them? How are hospitalizations now that these are real world working? How many deaths in the real world is happening outside of the clinical trials? And just keeping people up to date in that manner. The other thing, as you can imagine, fighting misinformation for vaccines, like your DNA is going to change, and explaining why this isn't going to happen, but in terms that they can understand. For example, an mRNA would need to enter your cell nucleus where the DNA lives. However, mRNA don't have the secret door code called nuclear access signal that will allow it to enter. So explaining why mRNA won't change your DNA in a science way. Misinformation about herd immunity. And then also during the winter of 2020, I reached a phase 5, and this doesn't really necessarily have to do with content. I think it just more has to do with my scientific communication journey. And this phase 5 is a phase of independence. And this is all sparked because I was hacked. My Facebook page was hacked in early February 2021 by an anti-vaxxer group, and they took over my content. I couldn't access it at all. I was literally, I couldn't do anything, and I just watched my ownership of my content just get destroyed. The other thing that happened at this time was I couldn't get through to Facebook. I had, close to 200,000 followers. And at this time, I recognized after a couple of days that I don't own this content. I rent this space from Facebook. And that was one of the biggest eye-opening experiences of my scientific communication perspective. That, eventually Facebook worked with me after. The only reason was because I have a girlfriend that works at Facebook headquarters that could get me in contact with the right person. So a week or two later, I finally got access to my content, but it wasn't easy. And I think that this needs to be at the forefront a lot more when we're using platforms to disseminate science, because this was a big threat to the following. People thought it was me talking about some of their misinformation, and that can do a lot of damage because of the trust that I built over the past year. And so what I did was I created a Substack. I'm not paid by Substack at all, but this was a way that I could develop my own content and own it. And this is now my primary location. I still copy and paste my newsletters to Facebook to send out, but this was one of the biggest lessons learned I have found throughout the pandemic. And then also this phase, and this is me actually today and yesterday and tomorrow thinking about what's the sustainability of this, right? So I found a gap between communication and the layman for COVID, but this isn't just a COVID problem. This is a problem among vaccines. This is a problem among gun ownership. If we talk about violence epi, it's a problem among mass shootings. It's a problem among HIV, right? Like the last presenter mentioned. It's a problem among a lot of scientific articles. So how can we jumpstart this in the future to sustain it across all topics of public health? And so, I know I'm over time. I'm sorry, Christian, but I was just, this was a pandemic of misinformation in many waves and continues to be waves. Some of these data-driven updates was the first wave, and there's a lot I learned from this phase, that we have a fragmented public health information sharing system. We need consistent messaging, and we need a formal forum to do this, away from the government, a way that there's a direct line from science to our community, and the other way around too. Scientific translation, learned a lot about this, specifically that there's a lot of misinformation out there. And I think I heard one saying that misinformation can go around the world once, but it'll or go around the world 7 times before science can catch up. And it's true that it takes a lot more effort to post something scientifically and translate it to the layman than an misinformation viral post. Science is illiterate among the public, and we need to change that, as well as, scientists can't translate well. We're not trained to do this, and that needs to change. Third phase behaviors, pandemic fatigue is real. Show examples, show case studies. This is where case studies is really valuable in epidemiology. And then my, fourth phase, vaccines and variants, learned a lot about misinformation, hesitancy, and personally, I learned a lot about immunology that I never thought I would have to learn about. And then finally, independence, right? That we rent space from social media and that we need a more sustainable forum for this direct line of communication. That scientists can infiltrate echo chambers instead of contribute to them. And I think that's a really important lesson learned. So and this is my last slide. I always end it with this, I guess, cheesy picture, but I do think that there's light at the end of the tunnel. I think that we have lots of fantastic scientific educators and communicators. We just have to, and we are banding together to figure out a way to move forward for public health and for our community. And so that is it. And I look forward to the discussion after all of the speakers to answer any questions.
Wow, thank you. Thank you so much. I cannot explain how much I identify with everything you just said. From the initial post with Italy to talking to the public to the stuff that's happening with Facebook. I've had many of those same experiences, not being doxxed in that way. That's crazy. I'm so sorry you went through that. But I think I've come to many of the same conclusions, and I think there's common themes between what you and Dr. Sokar were saying about iterating with the public, actually speaking to the public, because, I have been out through my own nonprofit talking to the public as well. And I've had the same experiences. People have good questions. They really can understand the science. We take the time to explain it in a way that's digestible and have the right images. So thanks so much. I want to introduce our next speaker. Changing gears a little bit, but sort of moving in the same direction. Also fighting misinformation of a different kind. So Professor Antonio Fernandez-Anta, I know from expert COVID cases modeling. So he's a professor of computer science in Spain. He has been, he's produced a survey called CoronaSurveys, which tracks symptoms on the web, and has been able to predict COVID cases in countries where there is either governments are not reporting data correctly, or there just isn't access to testing. This has been an incredible resource for COVID modeling, and one that we're taking forward now to try and predict the next hotspots in India and around the world. So without further ado, Professor.
Thank you, Christine, for the introduction. I see, yeah. So I guess everybody can see my slides. Yeah.
Yes, you're good.
Well, thanks for inviting me to give this talk. As Christine was saying, I'm in Madrid, and that is okay. If you want to see my team, it's not my team, actually. We are a team. It's a huge. We had overall more than 200 people, including all the translators and everybody. So you can go to our website and take a look at who has been involved. Okay, where is this coming from? As it was mentioned, I live in Madrid, and at the beginning of March, I was following closely the news in Italy, and there was the cover page of the main newspaper in Spain, El País, talking about 3,000 and change confirmed cases in Spain, while at the same time all the news were saying that there was not enough labs to test for PCR and to detect the actual number of cases. So I was very annoyed and by this fact, and how everybody was spreading the news. Yeah, we have only 3,000 cases, 3,000 cases, 3,000 cases. So I said, well, how can we do something more accurate? Well, a posteriori, something that could be done is if you know the number of fatalities, and you have an estimate of the CFR, which we knew from Wuhan, at least we knew later on from Wuhan that the CFR was roughly 1.38. And I knew 14 days later, that the number of deaths in Spain had been 4,000 in total. So I could have computed that the actual number of cases were more like 100,000, sorry, like 100 times more than these 3,000. It was close to 300,000. Unfortunately, I didn't have that data at the time. So what I did is I launched a tweet survey asking to people, how many cases of COVID-19 you know of. And Twitter didn't allow me to go beyond 4 options, so I just that's all I had. I got 700 votes in 24 hours, which was like a huge success for me. And then just by doing some quick computation, if essentially you add up how many cases these people are declaring, and you estimate how many people these respondents must know, and you divide one by the other, you get a rough estimate of what is the percentage of the population who has been sick. By applying a simple number of everybody here knowing 150 people, which is a well-known number in sociology called Dunbar, my estimate at the time was 160,000. Now I know better that the right or a closer to correct number I should use of how many people a given person knows, at least in Spain, is 77, and that gives 300,000 cases, which is almost spot on with the number of cases that you get from the fatalities numbers. Okay, in both cases, what is significant is we are talking 2 orders of magnitude higher than the official numbers. That led us to deploy this as a much bigger effort and a much bigger project. So in 2 months, we had, in a few weeks, we had it in several countries. And in 2 months, in May 2020, we had a survey that was deployed all over the world. It could be answered at the regional level in 150 countries, and it was translated to 60 languages. Essentially, the 2 main questions we were asking were the ones that we were using to track the number of cases, which was essentially, instead of assuming that the number of people somebody knows is 150 using this Dunbar number, we were directly asking, how many people do you think you know, and hoping that the wisdom of the crowd, the errors would aggregate each other and would compensate each other. So the average reach, the average number of people somebody knows would be roughly okay. So we were asking, how many people do you know, and how many of them had symptoms or had the sickness, and just estimating using something that has been called the network scale-up method. In fact, we reinvented, because we didn't know about this method until a few months after we were already in the project. So what is this? Essentially, why having this kind of indirect reporting questions is good? Because just a very quick example, if we have this population out of which we want to identify the ones with a blue circle around, which is roughly 1/4, 23.5. If I ask 3 people, my estimate is going to be pretty bad. However, if instead of doing that, I ask these same 3 people, how many people you know who have a blue circle around, and how many people do you know, period, and I do the same estimate, I'm very close to the real number. So this is something that is not new. Actually, it became 30 last year, and among other, it has several advantages. These are mostly, the red lines are mostly the disadvantages, the biases that you can have, but it has several advantages. The first thing is that is privacy. You are not asking for anybody's health status. You are asking for somebody's contacts. So all the data we have collected is public and available for everybody to use. Second, you're asking indirectly. So there is the issue of reaching many more people with less answers. So roughly between 50 and 100 times more people than the number of answers that you get. And the third is that you don't have the problem of people not be willing to talk about something delicate. For instance, this technique has been used to estimate the number of HIV positive persons in a community, when if you ask directly, people may not answer honestly because they don't want to reveal that they are HIV positive. Okay. Of course, there are other issues. People may not reveal it to their friends, so maybe the answers you get are not complete. But they have been used in that kind of context. And in particular, the very first application was estimating the number of fatalities in an earthquake, which of course it was impossible to do a direct survey. So this is like, for instance, the estimate we've been getting in Brazil. Brazil is one of the countries in which we've been getting more data because we've been putting money on the table. Actually, we have a collaborator from Facebook who has been giving us funds to promote our survey in Brazil. Both blue and orange lines are estimates that we're getting with our own application of this method. So the question is, this is the very first time this method is used in such a long time and in such a large geographical scale. So essentially, we are developing new techniques to obtain these estimates. The blue line is obtained from the number of fatalities. We are kind of happy with the method because we have published a paper recently in Frontiers in Public Health, in which we estimate the number of the incidence of COVID-19 in Spain in late April, early May 2020, and comparing it with a countrywide serology study. They tested 60,000 people all over the country out of a population of 47 million. And this is kind of after a few corrections, this is, in the diagonal is the results of the serology study, and the red dots are the results that we get at a regional level with our own surveys. As you see, all our dots are very close to the diagonal. So we have a very good estimates. We get very good estimates of what is the incidence in every different region of the country. If I zoom in, what I see is that our error at the country level is not too much, it's like 1%. And what is interesting is that we get this with less than 1,000 responses to our survey globally for the whole country, while the serology study implied 60,000 people being tested with 2 different tests, which imply, well, I mean, just looking at the economic dimension, we're talking millions of euros or millions of dollars. Of course, what you're getting with this study is one snapshot. What we're getting is a movie, because we're continuously estimating, we're continuously collecting data. We are now asking other things, like, how many people personally who will refuse vaccination, how many people have already been vaccinated. We added recently in some countries how many people have long COVID, which is something that is not really known. The incidence of long COVID is not easy to find. And well, as Christine, we've been trying to get some funding and some visibility by participating in challenges. So we were in the COVID-19 Symptom Data Challenge organized by Facebook, in which we were finalists, among the 5 finalists with PathCheck, by the way. And then in the pandemic response challenges, we got also an honorary mention. We were among the 10 finalists. In these challenges, one of the contributions has been working on forecasting, which was something that we didn't do before. We were more focused on obtaining data. Now we're also contributing by developing algorithms. I don't think I have time to go into how this is done, but actually our approach is very simple. I know other people are doing much more sophisticated approaches. Ours is a very simple approach with generalized linear model. We have a few statisticians in the team, and they said, okay, let's try something simple, and then we can go for something more sophisticated if that doesn't work. And what we are currently working on, like the last few weeks, is like using the same data from the Symptom survey from Facebook, the one that was in the first challenge. We have access now to the microdata, so we have individual responses, and we are using that to try to combine that with the survey responses, which is giving us an estimate of how many people somebody who's responding knows, and getting estimates at the country level, but also at the regional level. So for instance, these are our estimates in India right now. As you see, this is really, really scary, because what you see at the bottom, the green, yellow, and orange line, are the estimates based on official number of confirmed cases and official number of fatalities, while the direct questions and the indirect questions that the Facebook survey, these talk about 0.4% of the population being sick, while the other numbers, the numbers we're getting, are between 3 and 4%, one order of magnitude. So we're talking 40 to 50 million people infected now in India. We have also data at the state level. For instance, this is the situation in Delhi, which is talking more of 7% of the population, which is really, really scary. And what I'm very happy is that both curves obtained from two different methods are very close to each other. We are also getting we got some funding from the regional government of Madrid, so we have enough data from Madrid, and again, the data that we're getting, which is the blue line, matches quite well the data we are getting from this other survey, which are the other two lines. So we're quite happy with this, but unfortunately, we are not getting enough participation, and that is something that in order to do this for all countries, or even like all regions, or not even all countries, but especially for low and medium income countries, this could be a game changer, because the data is not reliable. We have seen that the data is not reliable in South America, data is not reliable in Africa, and data is not reliable in many countries in Asia. We think that this indirect reporting is very powerful, and in fact, we plan to keep using it in the future beyond the COVID pandemic for other types of pandemic, malaria, whatever. Where we are now trying to use our data with the data from this Facebook CMU-UMD symptom survey, Oxford Data and Interventions, Google Data Mobility, and kind of put it all together, working with Christine and other people in PathCheck also, and try to come up with algorithms that can make the best out of all this data. And well, a little bit of marketing. We just launched a crowdfunding campaign because, as I said, we're very short of funding. So if you can help us either promoting the campaign or contributing, we will be very, very happy. Essentially, the objective is to deploy or get more responses in India, Brazil, Ecuador, and Nigeria, from which the data, like Nigeria, the official data, the official numbers are 0. There's no COVID-19 in Nigeria when you look at the data from the Symptom survey, and it's much higher. And this is pretty much it. We have a few kind of informal publications. We haven't had time to really sit down and publish scientific papers, but we are happy with the results, and we are happy to be able to contribute and share knowledge, algorithms, data, whatever. Everything everything we have done is public, data, code. So if you want to access it, just let us know, or go to our website, and if you don't find anything, just contact me. Thank you.
Thank you so much, Antonio. That is really amazing. And as he was saying, we're working on a project right now, this minute, this weekend, sort of night and day, to try to figure out what the next hotspots are going to be around the world, where we can get oxygen quicker. And misinformation coming from governments is this giant problem. So governments, not reporting case numbers correctly, or intentionally trying to not have as much testing as they should. And the amazing thing about what Antonio and his team have done is they're able to outsmart that by going around it directly to the public, which I think is a theme we also saw with the communication work that our first two speakers were talking about. So with that, sorry, I'm speaking too much, but it's just all very inspiring. I think we can take questions, from the group.
So I think we have a question from Tao. So it's for Antonio. So the question is, are you also doing / planning nuanced information about symptoms that may help us capture spikes and predicting these?
Oh, sorry, say that again. Can you repeat the question?
So are you also doing nuanced information about symptoms that may help us capture spikes and predicting these?
No, and because we try to keep the survey very, very simple. We could, but the problem is that it's very unlikely that somebody is going to know individual symptoms of a bunch of friends. However, that information is in the Facebook survey. So that is something that I think is well covered in that survey. I think what we're doing is going to be more useful for other parameters that a direct survey is not going to be able to cover. For instance, long COVID is not as frequent as being able to be measured accurately if you are like 200 answers, because maybe that is going to give you like maybe one person, maybe no one. Instead, it's much more easy for somebody to know somebody and be able to aggregate. In fact, in the curve that I was showing, the blue one is based on direct answers, the red one is based on indirect answers, and the red one is always much smoother because it, in some sense, carries more information. But if we think it could be useful, we will. But I think that is already now quite well covered by the other surveys. So I don't think we should try to overlap too much.
Great, thanks. And I just wanted to go next to your actual question for the panelists, asking if I think the first two professors have visual material for India and COVID.
We don't right now. That's something that we're working with a number of other groups that are creating content as well. We're right now trying to assess what has been done already, to be able to collaborate with other folks and be able to advise on what we did on the HIV space, to draw on that to help advise on moving forward. It's something like we created for the COVID DB for kids, which is being used primarily on this side of the world. We'd like to do something like that on the other side. So if any of you guys have access to good visuals, etc., we would be happy to pull those together and be able to create a communication stream so that we're all working together versus in silos. I know we're trying so hard to work together.
Yeah, I couldn't agree more. And that's part of why I wanted to bring everyone together, because so much of what all of you are talking about are threads that PathCheck is also trying to do, so it just makes sense to sort of combine forces, I think. And so there's okay, so a question from Bharat. Hey, Caitlin, super informative talk. I'm curious if you see what you have started could be used to change the way patient-doctor information exchange occurs post-COVID era. Oh, we might have actually lost her. I know she I think she had an 11 o'clock meeting. Sorry, I can try to get that to her afterwards. Okay, so
So one thing I wanted to mention just on the previous question that was asked is that Kristen, myself, and a number of other experts are working on creating a video for India, a short video on home-based care, because a lot of our contacts are writing in saying that they need to figure that out because the hospitals are so flooded. So if any of you guys have any contacts or suggestions on questions that need to be asked, etc., this is something that we're going to be tackling very soon.
Absolutely. I definitely think there's a lot of people that will have dovetail with that, so we can definitely check back with it. Okay, so Karthik says, wonderful talk. Sir, why would be the herd immunity percentage of the population that need to be vaccinated? I heard Britain will achieve herd immunity in some months. Would be great to know. Is it 70% of the population or 80% or more?
I think that's for you, Christine.
Yeah, okay, I can try here. So herd immunity to which variant? I think that's the big question. So I think it would have been 70% for the original variant, but we now have halfway of a new pandemic going on with the new variants. So I think we're trying to update the modeling. So what we need to know is how well will the vaccinations cover the new variant? How well will previous infection cover it? And then account for, you know, maybe that will require 40% more people or 30% more people with a new booster in order to get there. So it's not such a simple question, and one that I think we're tackling right now computationally. I don't know if you have things to add to that, Antonio.
No, well, I mean, I'm not an epidemiologist, I'm not even a doctor, I'm just a computer scientist. So, I mean, I just maybe something that when we had one of our calls, you mentioned is that is not only how many people have taken the vaccine, had been vaccinated, or how many people went through COVID-19. Is also what's the behavior of the variants, because at least from the data in Manaus, I don't know if there is anything new about that. It looked like in Manaus there were many people that were reinfected just because there was a different variant going around. So if you were infected with a variant and then there's a new variant comes around and you know, your antibodies are not effective, then you are poof.
Yeah, exactly. So we saw places that should have been herd immune by infection, the city Manaus in Brazil, that then had an entire another wave that was even worse than the first one, worse hospitalization. So that's proof that these new variants are escaping immunity by previous infection. They are somewhat maybe escaping by vaccination, although that data we're trying to work on that right now. We don't have the numbers yet. That's something I think everybody is trying to figure out every day to try to figure out what's next. Yes. So trying to think what the best next question is. There's so many questions on the chat. Okay. Okay. So Todd says, wonderful talks. My question for Antonia, are you planning nuanced information about the symptoms that may help us capture spikes and predicting these?
I already answered that one. As I said, I mean, what is being done actually now by PathCheck, they are deploying a survey in India at the hospital level for patients, and they are going to be collecting symptoms. As I said, you know, for an indirect survey, it's much harder to go down to that level of detail. And so probably the combination, yeah, I forgot to mention that in the answer to the previous, before, that, we are going to also be combining probably the data that is going to come out from that other survey. So the survey that PathCheck is going to deploy in hospitals and in India, plus the survey from Facebook and University of Maryland, which is the actual entity who's deploying the survey and collecting the data. I think they will have enough data about symptoms to be able to use it in, for instance, for forecasting and predictive modeling, as we were saying before. Well, I hope.
Great, thank you so much. And I have a question for Dr. Sokar. So what do you think might be, based on your work with HIV and misinformation, what do you think the best way would be to reach people for vaccine hesitancy, which is, the big stumbling block right now that we are facing in this pandemic?
Yeah, I think the question to that is to really try to understand why that hesitancy is there and figure out which populations have hesitancies for particular reasons, and then from there go to figuring out how we would battle that misinformation. So a lot of the work that we did in HIV, we were just asking the wrong questions. You're asking the wrong people the wrong questions. And so trying to figure out what those questions actually should be will help us find the answers fairly quickly.
Yes, and I think the people working on surveys here would be super interested in maybe combining forces on that to figure out this vaccine hesitancy question, because I think this is maybe going to be the biggest misinformation battle that we have going forward in order to try and stop the pandemic.
Yeah, so just a very small example, when we had run a study in India for HIV and testing, so it was free to get tested. And so when we, ran a survey across many, many people, and all these people came back and said, no, we wouldn't get a test if it was available for free. The question that we had asked, actually, the reason why people were saying no was because the free testing was in government hospitals. So they would actually they wanted to get tested, just not in government hospitals. They wanted to be able to do it in private hospitals. So again, if we're not asking exactly the part that we're interested in, we will get answers for the wrong reasons and not even know it.
That is really amazing information, because we're right now at PathCheck have a team that's has ASHA workers. We're going out to communities and talking to people and having them report back so that we can get good data. And vaccine hesitancy, I think, is part of that. So understanding what questions to ask and how to get that kind of information would be really important. So yeah, I would love to talk more about that at some point. I'm sure other people would as well.
The ASHA workers that we've worked with in India have been extraordinary. I think the first step there was to figure out how much do they know and how much do they not know, and making sure that they themselves can translate the questions that we're asking properly once they get to the villages. Because there's a lot of loss of communication when you're playing telephone. And so making sure that, again, that what you're trying to glean is what you're actually getting.
Yeah, that sounds really important. And I'm imagine also with the different languages and.
Yeah, I just saw the question around that. So a lot of the misinformation has been in translations. And so we go through this very, very rigorous translation, back translation, retranslation process. And in the process of doing that, we've discovered some insane, misunderstandings done by very good, well-intentioned people. So like in China, for instance, you can get HIV from breast milk, and they had converted every instance of the word, I think we were talking about this the other day, of breast milk into just milk because it was taboo to say breast. And so, all of a sudden you've got all this misinformation that you didn't mean to have by translators that were all well assuming. And so similarly in India, the word for cure and treatment are interchangeable depending on how you're using it. So these back translations have been pivotal to making sure that you are communicating the right information.
Yeah, that story I think is going to stick with me for a lifetime. People thinking that they could get HIV from cow's milk, right? because of this translation problem. And I think so much of the misinformation is like this giant translation problem from scientists to the public.
And in a lot of when you're talking about scientific concepts, a lot of times there aren't simple words to communicate those concepts, and people get very scared when you're saying the word testing. They don't understand, is that really hard? Is it painful? Is it cumbersome? You know, is it so figuring out ways to relate it to things that they already have in their mental model that relates to their everyday life, to help them understand that it's simpler. It's really, really important.
Yeah, I mean, those are the kind of questions I get all the time, these super practical questions that I don't, you know, we don't think about. Yeah. So Antonio says, Pia, what do you think is more pressing, getting data or promoting safe, healthy habits?
The answer is both. We've got to have people working on getting awesome data, getting the right data, everything that we talked about with government data. There's people working around the clock trying to do the best job that they can, but making sure that we are getting the most robust data that makes sense is, we do a gut check there to make sure that you're able to serve the people the best that you can with that data. But then of course, with healthy habits is really important, and the data will help us drive those kinds of practices, because a lot of the people who need to have healthier habits need to see why those things matter. How do viruses work, and why is it important to wash your hands, etc. So I think that the data drives the healthy habits. It's important to have both.
Yeah, I totally agree. I mean, Professor Jalina was saying there was two problems in the pandemic: misinformation and the pandemic itself, I would say, and the third problem, which is a lack of data. And so they all kind of dovetail together, right? You can't have, one without the other. We need the data to be able to communicate, and then people to be able to communicate correctly, and then that communication to come back to us so we know how to speak to people. So I think it's all an interconnected web that we're finding here. But does anyone, Ron, do you want to wrap up maybe, or did you have more questions?
Right. Yeah, I think in the interest of time we could wrap up, but I can see that there are in general questions about how could we improve communication, and can we use similar methods that Dr. Soka was talking about for the PathCheck Foundation method, like using celebrities and voices people identify to. At least it's a huge thing in India. I'm not sure if it would be translatable to other places, but when they see the actors or renowned people come and speak about it, they're more motivated to do things like that. So I think there are generic questions on that, on how could we use them for the PathCheck surveys promotion as well. I mean, definitely that's something which we could consider, let's see if we can actually do something on those lines. It would be interesting to see their help. Yes, it's definitely there. But I'm just quickly going through to ensure that we didn't miss any questions. Looks like it's like most of the questions are covered. So yeah.
Yeah, I do want to quickly just plug both Dr. Sokor and Dr. Fernandez-Anta's work. So CoronaSurveys.org, if you can share it, it's open source, it's privacy protected, it's going to give us the real data we need to predict cases. And Dr. Sokor has an amazing website as well. That's like, everyone has been asking me, where do I find real information about the pandemic? How do we get real information to the public? And she has a database that has been expert curated. Doctors and scientists have spent a lot of hours to make sure that every article on that database has been fact checked and is correct. And it's a wonderful resource. So I also want to plug that. So that would be my ask. Yes, thanks. So Pia has her website in the chat, and so does Antonio. So, yep.
Awesome. So thanks everyone for spending all this time with us, and it was a really engaging discussion, and I'm sure every one of us got to learn a lot of new things. So that's amazing. Please do check out the YouTube channel in PathCheck, where we have the previous talks uploaded from other speakers as well. And if you're interested to work on any of these, please feel free to join our Slack community. It's tiny.cc/PathCheck Slack. Good day,
Thanks
everyone.
so much for having us.
Yeah, thank you
Really
so much.
inspiring.
This was amazing. Thanks.
Thank you very much.
Bye, everyone.